Hello and welcome all. Welcome to our session for today, the NCQA Patient-Centered Medical Home 2024 program. That was a tongue twister. We're talking about how we can unlock excellence today, and we're going to share with you what we think is a great roadmap to having a full application and the success in doing that. We're going to wait just a minute as folks are flowing into the session. My name is Deborah Johnson Ingram. We're just going to hold for just a few more seconds before we get going, but please welcome. Okay, it is 12:01, so let's get going. Again, welcome to our webinar, Unlocking Excellence, your roadmap to NCQA PCMH 2024 full application success. Again, my name is Deborah Johnson Ingram, and I have the pleasure of being your moderator for today's session. Before we get going on our content, I just want to give a fantabulous shout out to our organization, Primary Care Development Corp. We are a unique nonprofit in that we support the healthcare community in 3 different ways. We transform by partnering with healthcare providers to build capacity and improve services and outcomes, like in this session today. We invest and we provide capital to integrate services, modernize facilities, or expand operations. And we advocate. We promote policies that advance health equity and bring resources and attention to the primary care agenda. I want to welcome our amazing presenters for today. So on our presenter list, we have Dr. Ilse Bell from PCDC, Maya Morse from PCDC, Ndidi Ayer from Sun River Health, Adam Lipton from Sun River Health, and Clarissa Ospina Norvell from San Francisco Community Health Center, and Audrey Ng, also from San Francisco Community Health Center. So welcome to our presenters. Some housekeeping for our audience. This is a Zoom session. You should be pretty familiar with these sessions by now. We have a chat feature, and it allows us to communicate as this session is going on. This is a conversation, so to speak, besides some content detail being shared. So please feel free to chat as you would like. We will try to get to all of your questions as the session is going through. We will pause for moments for you to be able to ask questions. This session is also being recorded, so if you are concerned that you may not be able to catch everything in today's session, the session recording and the slides will be distributed after the session is over. Here are our objectives for today. We're going to do a brief recap on PCMH. Patient-centered medical home concept has been around for 16 years. So we're going to talk about where we were back in 2008 when NCQA first released their first set of standards to today. Then we're going to dive into the NCQA PCMH 2024 standards. And then we're going to engage you in a great conversation, a discussion about maximizing your PCMH incentives, because we're leaning on the fact that patient-centered medical home is really, to us, a prerequisite of having value-based payment success. So where it all began, from Joint Commission to NCQA PCMH program, many of us may not recall that the origins of PCMH was actually an approach developed by pediatricians back in the early 1960s. And it was an approach to sort of care for patients and their families of the developmentally disabled community. And sort of fast forward to around 2006, 2007, there was an organization that convened some sort of heavy hitters when it comes to healthcare. The Primary Care Collaborative convened the American Academy of Family Physicians, the American Academy of Pediatrics, the American College of Physicians, and American Osteopathic Association. And they got together and they said, you know what? We need to take some of these patient-centered concepts that was developed by the pediatricians way back when, and sort of, make them into something that lives and in our current healthcare delivery system. So they released the Joint Principles of Patient-Centered Medical Home back in 2007. It described an approach to providing comprehensive primary care that was going to facilitate partnerships between patients and their families. And then, that was sort of like the beginnings of all this stuff. PCMH for them describes mechanisms for organizing primary care to provide high quality care across a full range of individuals, right? And all their different healthcare needs. NCQA released their 2008 standards in response to these recommendations that were released by the PCC group. So their model, PCMH, Physicians Practice Connections was the name of it, because that was a program they had already going with NCQA, and they added the patient-centered medical home recommendation. And that model was introduced to the public back in 2008. And now we're in 2024. So it's so interesting how we've had this sort of really amazing timeline of activity that occurred since then. Here I'm sharing with you just a quick timeline of sort of like some major events that happened along the way. So on your far left, you'll see in orange, that was the release of the NCQA program. But you'll also notice on the bottom towards the middle, on the left-hand side, in 2010 and 2011, there were 3 other organizations that released their set of standards. So yes, NCQA is one of 4 organizations that has a set of comprehensive recommendations, standards, that will help an organization build up their patient-centered care delivery model. Those other organizations are the Utilization Review Accreditation Commission, the Accreditation Association for Ambulatory Healthcare, and Joint Commission. So they're also known as Europe, AAAHC, and TJC, in case the other long names are not familiar to you. Fast forward into 2018, NCQA had released a white paper that the Millman organization helped them put together. And it was the first time that we were seeing that it was evidence that primary care providers benefited from a patient-centered medical home environment, and that it helped them prepare for value-based payment. I think we were seeing this all along, but back in 2008, VBP wasn't a thing as much as it is today. And now that we see that PCMH literally is a road that can help you be successful in your patient-centered medical home. PCMH can help you be successful in your VBP work. In 2024, NCQA has 16 years in the game. PCMH recognition from NCQA is the most widely adopted PCMH evaluation program in the country. Based on their numbers, they have 10,000 practices that are recognized. That encompasses over 50,000 providers, and that is across in the nation. Today, they have 6 concepts. Back then in 2008, they had 9 standards, so now they're called concepts. Those concepts are team-based care and practice organization, knowing and managing your patients, patient-centered access and continuity, care management and support, care coordination and care transition, performance measurement, and quality improvement. And my colleagues are going to actually take you through each of those concepts in just a moment. NCQA recognizes primary care providers. They recognize physicians, MDs, DOs, and NPs. So let's get into it. I'm going to transition to my colleague, Ilsa, and she's going to take you through the first concept, team-based care and practice organization.
Thanks, Deb. I appreciate the handoff. So first, I'd like to say, for any questions that you have, if you can please enter those in the chat, and both Deb and Maya will, while I'm presenting, they will answer your questions. So as Deb said, we're going to start off with team-based care, but I want to start by just saying a few things. The PCMH standards are guidelines. And so when you start your PCMH transformation, you're going to download the standards and guidelines. And they're just that, they're guidelines. They're not rules. However, you must stick to the evidence that NCQA requests. So a lot of practices or organizations think if NCQA asks for a report, I can give them something else. No, you cannot. If NCQA asks for a report, they want to see a report. If NCQA asks for evidence of implementation, they want to see evidence of implementation. So although they're guidelines and not rules, you do have to stick to the evidence that NCQA is asking for. And by evidence of implementation, what NCQA means is generally patient examples. So an actual patient that's in your population, they want a redacted patient example, or sometimes they're talking about materials such as a brochure or some sort of agreement that you have executed with another organization, something like that. The other thing that I want to say is that more is not better, it's just more. So when it comes to evidence, stick to details. Details are better, more is not better, and that your evidence should stand on its own. So let's start talking about team-based care. I want you to take note that team-based care is the first concept of PCMH transformation. That's critical because NCQA considers team-based care the foundation of patient-centered care. But what you will not find in any standard and guideline that's created by NCQA is rules, again, about what teams or care teams are supposed to look like. They're not prescriptive about that. Your care team can and should be unique to your organization. There is no right or wrong way for care team construction. But what NCQA does ask you to do is to describe what your care team looks like. So provide the name and the credentials for your PCMH manager and your lead, but make sure you include their role within your organization as well as their credentials. Are they the NP, the MD, the LCSW? It does not matter. Again, your care team is your care team, but you do need to include what their role is within your organization and their credentials. For TC 3 and 4, you must be able to demonstrate that PCMH is an essential component of the work that's being done. So those are electives. You do not have to do them, but if you choose to do them, you must include how PCMH is a critical part of that collaboration. A lot of practices think, well, we have this fabulous collaboration with this organization that's right next door, but if PCMH or anything related to patient-centeredness is not part of that collaboration, it's not going to be good evidence. The other thing, bullet number 4, electives carry a higher burden. So make sure that your electives actually say, in terms of the evidence, what you think it does. Again, your evidence needs to stand on its own. On the right side, I've included some things that I want you to consider. Documented processes are not prescriptive. They can be, again, policies, workflows, flow sheets, agreements, whatever. It does not matter. And NCQA does not have a rule around that. For your huddles, make sure that your huddle evidence, you're discussing patient issues, not who's out for the day, not who needs to leave early as part of the staff. Next slide, please, Deb. Okay, knowing and managing your patients. This is the most dense of the 6 concepts. As I say on the right, there are 29 criteria in this concept area as compared to everything else. This has the most criteria. This is the population health concept. And that's because what you're expected to do here is to compile and track relevant information on your patient population. That's what population health is. And what that allows you to do, is to determine which conditions are most prevalent within your population. And that's basically what NCQA is asking you to report. Now, there's a lot of reporting in this particular concept. And so, as you can expect, the evidence will include things like reports, but it may also include redacted screenshots. And again, that could be screenshots like patient examples. It could be screenshots from your EMR. It could be screenshots from another organization's agreements, whatever. But if you're using any patient examples, you must make sure that they are not test patients. They must be actual patients. So a depression screening example must be an actual patient example. What's contained in this particular concept is also the comprehensive health assessment. that's probably done at your annual visit. Your policy must address each bullet that is in the standards. There are, I believe, 7 bullets, and your policy must address each bullet. If you are a pediatric or an adult-only practice and something like the developmental or the advanced care planning is not relevant to your particular organization, then of course, that does not need to be included in your policy or your workflow. However, you will need to make note of that in QPAS. So the system that NCQA uses for you to upload all of your evidence, you will simply just need to make note, we're an adult-only practice. We do not see children, so you're not going to provide that evidence. You get a pass for that. The same thing if you're a pediatric practice and you do not provide any information or documentation on advanced care planning, you would need to provide that information for the advanced care planning bullet. But just make sure that you are providing all of the other evidence for all of the other bullets. For KM3, depression screening and follow-up, rate. Rate is very important there. So I suggest that you get started early on that particular criterion, because you want to make sure that you're meeting at least 80%. No, it does not say that in the standards and guidelines, but trust me, you will find if you come back with the rate, and you see Deb's face, you see Maya's face, if you come back with the rate that is 60%, you're going to get questions during that check-in. Trust me. So you want to make sure that your rate is at least 80%, and if you don't meet that, you have an explanation for it. Your evidence of implementation must be a patient example, a patient that's screened, that is positive, and then you have evidence of follow-up. KM9, the third aspect of diversity, must be someone, or the third aspect of diversity cannot be language. It can be veteran status, it can be diversity status. The standards and guidelines actually give you some very good examples, but again, your rate there is very important. Race and ethnicity, you should be capturing that on every single patient that is seen. The same thing for that third aspect of diversity. For the SOGI, which stands for sexual orientation and gender identity, you are allowed to not ask that question for any patient that is less than 18 years old. And your rate there can be less than 80%. The expectation there is that you have some patients that may say, none of your business. So you should have some option in your EMR that allows for you to include a decline to specify or I choose not to disclose option for the SOGI. And that rate can be whatever that rate is, because people have the right to not tell you what their sexual orientation and gender identity is. But make sure when it comes to that third aspect of diversity, however, that choose not to disclose or do not specify rate, that rate is not 50, 60%. Because again, you want to make sure that you are ensuring that you are asking the question and you are getting an answer from the patient. I made a note of saying that KM14 and 15 are not the same. KM14 is a medication reconciliation after a transition of care. KM15 is an up-to-date med list. So a patient coming in for their annual visit, and the provider is bring in that brown bag of all of your meds. Let's see, are you still on all the meds that I prescribed last year? KM14 is only after a transition of care. All of your EMRs have that TOC button. If you're not hitting that TOC button and doing that med rec, KM14 is not that report. So the TOC button gets hit, you do the med rec, that's the KM14 report. The rate for KM14 and 15 should not be the same. They should not be the same. Okay. Community resource list should be based on your SOGI data, should be based on your diversity data, and should be based on your social determinants of health data. So that means that you should be gathering those 3 points of data. Next slide, please. Okay. Now this is the money shot. QI. This is the pain point. And I'm going to bring in Audrey and Clarissa in a minute when we talk about things to consider, because this was the pain point for the San Francisco Community Health Center when we were working through their transformation. So just a few things to note. For KM and QI, get started early. You do not want to find out 2 months before the end of your 12-month transformation period that your rates are not what you thought they were going to be. I just said your depression rate needs to be at 80%. You don't want to find out 2 months before you're at your 12-month period that your depression rate is 49% for all of your sites. So get started on your KM and your QI reports early in your transformation. For all of your reports, I put it here under QI, but for all of your reports, your minimum denominator should be 30. For only QI, your reporting period has to be the full prior calendar year. You can use any reporting period for any other report, for access, for KM. But for QI, your reporting period must be the full prior calendar year. And so what I noted here is, of course, we're in 2024, so that would have to be January through December 31st of 2023. For the Patient Family Council, if you're going to use that, and again, that's an elective, you have to make sure that your discussions describe QI. So if your Patient Family Council are talking about how much they love the new lighting in the bathroom, that's not a discussion of QI. Their discussions should include something about QI. And now, Clarissa, Audrey, the QIW. How was the QIW and that whole process for you? Can we talk about how putting that document together, was that a pain point for San Francisco Community Health Center?
Good morning, Elsa. Thank you.
Good morning.
Yes, I mean, I think anytime we have to do a workbook for the PCMH transformation process, there's a pain point there. This was one of ours, was trying to put this workbook together. And I want to echo what you said, to get started early, to get that baseline done as soon as you have an inkling you're going to go through this transformation process, because then you will identify where your problem areas are. And surprisingly enough, you'll see, unfortunately, maybe your metrics aren't so as great as you thought. And then you'll have to because you have to go back a whole year. So that's a long time, especially in your EMR, to look at an intervention that was implemented. And I think the hardest part for me in particular was identifying these interventions and writing them in a way that were not just a process, but patient focused, because that's the goal of PCMH, is involving the patient and identifying goals. So yeah, it was a challenge. I would say it was a challenge. So it was helpful to do a baseline and look at our population and identify where we were going to target some of our interventions.
So
yeah, and I'd like to add that
Audrey.
you should, hi, good morning. You should
Morning.
check with your EMR about having a PCMH reporting package. So when we started our transformation, we were using ECW and they had a PCMH reporting package. And that typically means the standard reports, the ones that are required, not the electives. They may not have reporting for electives. So the diversity report, medication list, those are all standard reports, and they will have that. So you just run the reports, you choose your time frame, and you can run the reports. So it's a good idea to check with them if they have that. We are now in Ocean Epic. They don't have a package of reports, but they do have some reports. You just have to find them. And the other reports, you just kind of have to create yourself. And some of them are available through UDS. If you're an FQHC, you have to do UDS reports, and some of the data can come through the UDS reports as well. Otherwise, you have to create your own. So for the reporting piece, start with that. run the report so that you can figure out what your baseline is. And as Clarissa mentioned, decide which metrics you want to use for quality improvements.
Thank you. So I do want to just make a point of saying the whole patient versus process focused, that was a struggle for us in terms of the intervention. And what that means is if you're thinking about, say, increasing something like a depression screening, your intervention can't be increasing documentation, because that's not improving or increasing screening. That's just increasing documentation of the screening. You want to get more patients screened. So you want to make sure your interventions get more patients the service. How are you going to get more patients identified that need to be screened? How are you actually going to complete more screenings? So that's the difference between a patient-focused versus a process-focused. And so we went through a couple of iterations, didn't we, Clarissa and Audrey? We went through a couple of iterations of interventions because there was a lot of, oh, okay, my thinking is increasing the documentation and I need to, but we did, and you can add that process as an additional intervention, because of course you do want to make sure that you're documenting the work that you do. Once you have the screenings done, you want to make sure that you're capturing it in the right places. So there is that, making sure that that gets done. Is there anything else you want to add about the QIW process or the work that we did on the QIW?
No, I think just that it really was a challenge, and it was a different way of thinking about our quality assurance program. And for me, it was just, I don't know how many times you had to tell me it's not patient focused. Where's the patient focus? And I'm like, this should be really easy. I've done QA before. But it was just the concept I couldn't wrap my head around. And when I finally got it, I got it. And
right.
It was, okay, so how are you going to improve your screening? And just to be concrete, we included our medical assistants and said, you will screen every patient who comes into the clinic. You will document that PHQ2, PHQ9, and then you will report to the primary care provider what for elevated PHQ2, PHQ9. And then there were interventions based on that. And I do want to say also with Audrey that Audrey's our quality assurance manager, that she had to work a lot of magic with the database that we had to extract from Ocean Epic. So, just be prepared if you have a quality assurance person or someone who runs your numbers. This is a really heavy lift for them. So the sooner you can get them started. And I'm optimistic, that Ocean is going to implement some improved PCMH packages for the future, because Audrey really had to do a lot of data extraction and twisting of things in tables. So, but Audrey's super great. So was really great to work with Audrey. So you have to have a really great data person to support you in this process. So if you don't have one, get one.
Yes. Thank you both. I appreciate your input, and I'm going to move on to Maya. Thank you so much for your time and attention this morning. So I'm going to hand it off to Maya.
Great. Thank you, everyone. And thank you all for joining us today. So I'm going to move into patient-centered access, which really has always been a cornerstone of the patient-centered medical home model. I would say it's evolved quite a bit. Early on, there was an enormous emphasis on having reserved same-day appointments. And while they still want us to ensure that we have same-day access, it's expanded quite a bit. And the focus is more on monitoring our access and continuity processes, making sure that we have adequate means of patients actually seeing patients in the after hours as well as during office hours, monitoring our clinical advice to ensure that we can answer calls during office hours and after hours. And then of course, monitoring our actual timeliness of response against what we say we are going to do within our policies. And so just as Ilse was saying, you know, they are not telling us exactly what we should be doing or what our time frame for response should be. They just want to know that what we've written in our policy is what we're actually doing. So just a few areas to really focus on. The after hours appointments continues to be a significant challenge, particularly for some of our smaller practices that don't necessarily have the ability to accommodate after hours. That's something to start working on early. If you don't have after hours at your practice site, you can use sister practices or a practice that you have an MOU with to ensure that you can offer that type of access to your patients. And just so you know, business hours is considered to be 9 a.m. to 5 p.m. on weekdays. Anything in the evening, in the early morning, or weekends, that would all be considered after hours. They also want us to, there's been an enormous emphasis during sort of the full transformation submission, as well as annual reporting submissions, on tracking our clinical advice calls. And this is a very challenging report for many organizations to track, because we don't necessarily differentiate between calls that come in asking for an appointment and calls that come in asking for clinical advice. If you are able to differentiate those calls, it would make your life a lot easier when it comes to running this report. But what NCQA really wants to know here is, are you responding to clinical advice calls within the time frame that you say you will? And are you doing that according to your during office hours time frame and your after hours time frame? And they want to know this for at least a 7-day period. Of course, more data is often better. So if you want to run it for a whole quarter, if it's available to you through your EMR, then that's great. If not, you might have to do this manually. And I would say even now in 2024, we still have organizations that we have to sort of put together a manual report. This is not ideal for a large organization such as that Nadidi and Adam with 31 practices, but something to keep in mind. Build those reports early. So some additional things to consider. We need to be monitoring our continuity with the PCP. So basically, whoever is listed as your patient's PCP, we want to know how often is that patient actually being seen by that designated provider. And the goal is to have it 80% or higher. And again, it's not necessarily written in the standards, but that's what they're looking to see. And if for some reason it is not written in, you don't have 80% for a certain site. Let's say it's a practice that works with residents, or you've had some transitions, maybe some providers on leave. Make sure that you're including that information in the note so that NCQA knows on, and you are acknowledging that you are not at 80% where you want to be. Additionally, in the transformation standards, they now want us to begin monitoring our panel size, which I actually think is wonderful, because this is a huge area of need for many organizations. What I've shown you here, and the link is in the slide itself, is a really cool AAFP calculator that you can download. This is the Excel version. They have a version that you can do right on the internet. And it is a method for figuring out what your ideal panel size should be, based on all the unique characteristics of your practice. So check it out, take a look. It is an elective criteria, but again, a really good thing to know about your practice, your group. Now, I do want to engage Nadidi. So Nadidi works at Sun River and does PCMH with many, many practices. So what are some of the key challenges or tips that you have for the group around access to care?
Yeah, so thanks for having me. Great to be here. I will say that one of the challenges for us around access to care is that piece in terms of identifying patients who are requesting clinical advice during and after hours. It's ever evolving for us. So at this point where we're at is we are able to identify those calls. We still do have a manual process in terms of ensuring that the clinical advice is provided within the time frame that we have specified. But what we've done is we've essentially developed a workflow where on a quarterly basis, there's a manual report that's done, where we're just randomly selecting those because we're able to like pull data on all of the clinical requests. And so we just on a manual basis do an audit on those like reports that we've essentially pulled. And the great thing is that for us, since it's just a part of our process, we don't really have to worry about like when the application comes up of like, you know, running and trying to figure out to like pull this report. It's just something that's just been embedded in our practice, even though it's manual. So we hope that, you know, in the future, we can be able to pull this, you know, into some type of automated report. But I would say, you know, what's worked for us is just kind of embedding it in the workflow throughout the year.
Smart. Great. Okay, next slide, Deb. So our next section is on care management and support. So this is one of the most challenging sections for many practices that we work with. The idea here is that we are identifying a high-risk group of patients. This may be through very organized risk stratification. It may be through a high-risk criteria that you establish. And then once we have identified patients that need care management, we actually do care plans on those patients. And so both pieces are very, very important. What I've included here on the left side of the slide is some information about who should be included in your risk stratification criteria. And so they want to make sure that we are considering behavioral health needs, high utilization of hospital services, chronic illness, and it may be more. You can have multiple, you can really have as many diagnoses as are relevant to your population, as well as social risk factors. And what they do ask is that you lay out, you know, how many patients have been identified as high risk and what is your criteria so that you can cross-reference that. As mentioned before, the sort of golden number is 30. We need to have at least 30 patients per practice site that have identified as needing care management. This, depending on the size of your practice, this could be very easy and this could be very challenging. I would say, particularly for pediatric practices, it can be more challenging, and that's where you may need to rely more on some of your social risk factors when you're establishing your high-risk groups. And then once you have identified those patients that do need care management, they do want us to be conducting care plans, and how those care plans are completed, if you have a very comprehensive care management program, or if you have your providers and your care team actually completing those care plans, is really up to you and your staffing. But what I have listed on the left is a list of the requirements for what should be included in that care plan. And it is really important. Some of those areas are elective, but I really encourage you to make sure that we're using consistent templates across all of your practices, all of your providers, and that we have designated fields for each of these sections so that they are not forgotten. So we want to make sure that we're always including our problem list and our current medications, expected outcomes, treatment goals, our patient preferences and goals, any barriers to actually achieving those goals, and a self-management plan. Those are really all of our core components for the care plan itself. Now, they have added within the 2024 transformation standards an emphasis on person-centered outcome goals and measures. So this is interesting. This is technically new. It is elective, but do take a look at it. The idea is that we are establishing goals that are specifically person-centered, and then we are measuring how we do within those goals. So of the patients identified as needing care plans, we need to make sure that 75% of them have a care plan completed in the chart that's updated at least annually, if not more frequently, really ideally at every visit. And then I always want to make sure it's important that the care plan is given in writing. This is not elective. This is something that must be done. And check your after visit summaries, because it is not always included in the after visit summary. Naditi, any tips and tricks around care management?
Yes, yeah. So this one definitely is one of the harder ones, I would say, that over the years we've just continued to improve upon it. So we started out in terms of risk stratification that we were kind of doing it manually. Thankfully, at this point, we've been able to employ like a risk stratification algorithm in the background of our electronic health record. And so, one of the big things is that you want to find a way to easily inform your care team that, hey, this patient is eligible for care management. So we were able to, one, get that risk stratification algorithm. That was helpful because, doing it ourselves in the past, it just really gets complicated. So we have a risk stratification score that, and just to make it easier for the care team, we don't have the score per se visible to them, so that no one needs to kind of like remember that, oh, a number 7 is, that's the ding that makes a patient eligible for care management. What we've done is we just really have what we call like PVP alerts. So they pop up in the reason section for the visit. And so the patient is eligible for care management, the care team will just see that it says a PCMH self-management goal is due for that patient. One of the tips I will give is that I think that on a yearly basis, it's really to your advantage to, look at your population and understand if you need to adjust that risk management score. So for example, there was one year where we were just looking at patients that were a number 7, because what we try to focus on is to look at those high-risk patients that are really about 5% of our population. It changes, right? So what we found is that in a reoccurring year, it wasn't just the patients that were risk score of a 7. It was the patients, we should include the patients that had a risk score of 7 and 6. So I think that is really helpful, just to always be assessing your population. And then the other thing in terms of, I think Maya, you pointed at it in terms of having templates. That's been very helpful for us. So we aim to try to have the documentation and structured data fields so that we can pull a report to just be able to identify, okay, of all the patients that were due for a self-management goal or care plan, what percentage of those patients had the care plan completed. It's also helpful for the team because, it's the structured data that really shows them that, okay, you want to assess the patient's barrier. You want to look at the patient's progress towards their goal. You want to now, communicate and document the follow-up time frame in which you want to bring that patient back in to like assess their progress. So I think that that's been really helpful for us. It's ideal. We really try to just have like systematic documentation, because if you don't, then that's when you have to do those like manual chart reviews, which we've had to do at times, and it's challenging. But really what we aim for is to be able to have it all in structured data and then to be able to pull a report. Another thing I'm going to just say, and I kind of spoke to it, when we were talking about access to care, is like just utilizing those reports throughout the year. So just making sure that you're pulling the report on a quarterly basis so that you can understand, you can pick up on, are people documenting in our structured fields? Is there any, is there any retraining that we need to do? Because the information is usually always in the progress note, but what we're really striving for is for it to be in the progress note in a way that we can easily pull out. So.
Fantastic. Great suggestions. Basically reviewing and reevaluating your high risk groups on an annual basis. And of course, having everything in the structured field. I love it. Okay, next slide. So our last area that we're going to talk about today is care coordination and care transitions. So basically, in this, we are looking at 3 main care coordination areas, which is looking at our lab and test tracking, making sure we are flagging and following up on any overdue results, and of course, designating when a test result would be considered overdue. referral tracking, which is fairly similar in that, again, we need to identify what is the time frame that this referral should be completed in, and when should we be following up either with the patient or with the specialist to obtain that result. And then finally, our coordination and communication with a hospital or inpatient environment. And very, very important, I think that this is an area that has changed quite a bit over the last 10 years that Patient-Centered Medical Home has been around. We have seen an increase in CCM and transition care management programs and follow-up. We have also seen some increased use of technology. And so looking at the health information exchanges, we have one in New York State. It's taken some years to get going, but those groups that actually use it can now finally see when their patient has hit a health system that they don't necessarily have a direct agreement with, and obtain the necessary documentation and information about that visit. So very, very important. Going back to some of what Ilse was suggesting, it's very important if they say that they want to see tracking and follow-up for a test or imaging tracking. They want to see the whole thing. The "and" does not mean it's optional. It means they absolutely want to see a full example that's tracked from the very beginning all the way through to the end, including all communication with the patient, the specialist, whoever it may be. Don't leave anything up to NCQA to try and figure out. Make it very clean and very clear with all your examples here. And if you do that, then really we should be able to tell an entire story just through those screenshots and get as few questions as possible from NCQA. So just a few extra things to consider before we move to Adam. Make sure if you have access to it, do set up your health information exchange. It can really, really help you during these care coordination examples and processes, particularly when it comes to communicating with the hospital proactively during a patient transition. And finally, make sure that we're downloading all the summaries and information and actually making sure it's available within the patient chart. Just because you can access it through a partner health system or through that exchange doesn't mean it's necessarily in the patient's chart. So a good word for the wise. Okay, so let's skip a slide. So we have today Adam Lipton, who is joining us from Sun River Health, and he has been managing the value-based care program at Sun River Health. And so I'd love to hear from you, Adam. We have a few questions on the screen. But tell us a little bit about some of your monitoring for PCMH incentive payments and also for value-based payment programs and how you're really optimizing that for Sun River Health.
Sure, thank you, and good morning and good afternoon. So just in terms of what we do at Sun River is pretty basic, but pretty powerful. So what I mean by that is we make about $4 million a year in PCMH incentives that are easily trackable. However, we have to monitor that because that's a big number. And what we've found is the state as well as the managed care companies need babysitting. So it just doesn't work perfectly without oversight and input and tweaking. So what we've done with Indeedy and some others is created a little task force that includes revenue cycle, includes insurance credentialing, and includes those who maintain the NCQA website, because those are the stars that have to align in order to maximize this in all the different capacities. And I think it's really paid off for us as we've closed the gap. Years ago, we were probably short $1 million a year. So we're really happy to have closed that gap, but it takes effort. So using there's twofold. There's fee for service in New York State, PCMH add-on. So we have to look per provider, per location to make sure we get the payment and the stars align at a provider level. So those are monitored, using our analytics, which, I think everyone understands analytics is a big part of this. But now we're looking at the actual payment if it's fee for service. And then the second component is, and then tweaking the NCQA website, quite honestly. Let's say we're not getting it, the provider's missing as a new hire or whatever the case might be, that constant maintenance needs to be done. And then similarly, we look at the rosters of attributed patients, which overlaps to risk contracting. So we get a roster, some plans we're contracted with, some plans we're not, or, we're capitated with, and some we're not. And, but either way, they can give you a list of the patients who are assigned to your primary care providers. And typically what we do is a simple pivot table that says by location, by provider, does it match with NCQA? And you just, in New York, we get $6 per member per month. So we just do the simple math. And then we compare that to the payment of the insurance. And if there's no variance, we're perfect and they're off the hook. Some just pay 100%, most don't. And you've got to find out the discrepancy. And it could be as simple as they have the wrong address for your location. And if the stars don't align, you won't get paid in New York. Or if they have the wrong provider. So a provider leaves or is deceased or whatever, if they have a panel, you're supposed to get paid. But if the payer terminates them or NCQA terminated them prematurely, essentially your stars aren't aligned. So you have to move panels and just do credentialing to maintain that the money flows as you desire. So that's it in a nutshell in terms of the first bullet of how we monitor, PCMH payments. If you guys are ready, I can transition to, value-based care. So those patients who are attributed to us, essentially, we use the rosters of patients to say who needs care. We're actually responsible to close the gaps in care for quality measures. We're supposed to keep them out of the emergency room. We're supposed to do transition of care, and we're supposed to properly risk code. All of that aligns with the measures you guys have talked about in prior slides of transition of care, risk coding, risk stratification. It really lends itself well, so you don't have to start over. But when you get claims data in a risk contract, you actually are enlightened to where your patients are going. They could be seeing another primary care provider, or they could be just going to the emergency room and not getting care from you at all. So you just need to divide. What we've done at Sun River is divided membership and engagement, and we've got analytics and dashboards to analyze, are they seeing an outside primary care provider and we need to get them assigned to someone else, or get them re-engaged so they know we're their primary care provider, or if they're going to dental or behavioral health or some other specialist only, we need to engage them in primary care, because ultimately if they're assigned to you, you've got to maintain them and maintain their gaps in care, maintain their costs, maintain their risk scoring, and follow up on the hospitalizations. All of that, there's like 20 prongs in this multi-prong approach, but membership is one. And a simple question I just happened to see, Sun River Health is a federally qualified health center. So just to give you some background, we have 52 locations, 400 providers. We're multi-specialty. We've got about 35 dentists, 200 primary care providers, and the rest are specialty. We're heavy on behavioral health. And in a risk contract, essentially dental is excluded. However, behavioral health, medical, pharmacy, hospitalization, specialists are all included. You're responsible for the entire health journey, excluding dental. So those are in your claims data, whether you're in a Medicare MSSP contract, ACO REACH, level 1 or level 2 or level 3 risk contract, where you have limitations on the risk you take. All of the same kind of measures are needed to measure membership and activity of new members, as well as old members, to make sure they're all being monitored and risk stratified and prioritized. Care management is another vertical. Transition of care is another vertical. Gaps in care is another vertical, because risk contracts have alignment to clinical quality measures. So sometimes, based on either readmissions to the hospital, or if you don't make your quality measures percent-wise benchmark, you don't get any profit. You might even have a surplus, but they withhold it because that is the devil's in the detail of your contract, that it might be contingent on making those. So the way we incorporate this in a nutshell, we take that external data and do our best to make it accessible in analytics, but also, as Ndidi was mentioning, we have automation that inserts pre-visit planning, as well as maintenance of the system in different ways. So we do the huddle kind of electronically, and say they're due for an A1C, they're due for a foot exam, they're due for an annual well visit. That all is inserted into the EHR, into the chief complaint. So everyone in the care team knows what's due at the time of service. And we roll that in a rolling 7 days. In addition, we auto load templates to basically, enforce the quadruple aim, where we try to reduce duplicate testing, reduce keystrokes, increase retention, and increase patient satisfaction, all striving towards just reducing cost and efficient and making things more efficient, in the full circle of care. So I'll pause because I think there's only 4 minutes left for questions.
Yes, please, what are your questions for Adam? I know that was a lot of great information, but we do have a few minutes left. We would love to hear from you.
If you raise your hand, you can ask the question. We can unmute your line, and then you can ask the question if that makes it quicker and faster, easier. And it could be any question from the content we shared so far, including Adam. So as we wait for questions, again, feel free to ask. I'm just going to share with you all, this is a national call. We have folks who are across the nation. There is a resource for those who are trying to identify, do I have something like New York has or what California has in terms of opportunity for incentive payments? The organization PCC, Primary Care Collaborative, they were the sort of orchestrators of the joint principles. They maintain a map, an interactive map.
Deborah, I think you just went on mute.
Oh,
but
sorry.
we do actually have a question from Yolanda, not to interrupt.
Okay.
So Yolanda, please go ahead.
Hi, good morning, good afternoon, everyone. I had a question for Adam about the template that he has auto-loaded into his EMR. How does that work?
So we have a platform under our MSO called Solutions for Community Health that has automation. So essentially, based on the triggers in pre-visit planning, just like if you manually say, oh, this person's due for an A1C, we have a template in eClinical, and we happen to have eClinical that I don't think was mentioned. We actually identify that, and before the patient is roomed, that template is preloaded with the test already ordered. But we've got a list of 20 templates that we incorporate. And in addition to that, we've got auto coding. We have even automation that captures PHQ-9, social determinants of health, sexual history, and we're adding a few more for substance abuse, where those are pre-populated before the patient's roomed. And one of the things that helped the clinical staff enormously through the pandemic was loading standing orders, because every patient needs a standing order annually, not necessarily related to PCMH, but we weren't compliant with our own policy.
Right.
So it's hard work, during the pandemic when there's less staff. This has been, one of the saving graces for us to kind of reduce keystrokes, also work towards all these goals that we have. And those templates can be customized. So we're working on loading comprehensive physicals for extended age groups, as well as Medicare annual wellness visits. And we use our analytics to determine, AI and analytics to determine what's due. So is it an initial well visit, or is it a subsequent well visit? So there's revenue to make, risk coding to do in those types of visits. Hopefully that answers your question.
Yes, it actually did. And because we use Epic here at Family Circle of Care here in Tyler. We're in Tyler, Texas. And so I was just wanting to know if you would be willing to at least share a sample of one of those templates. So perhaps we can build something within our Epic system that can be as useful for us.
Sure. I wish it was cut and paste. Even in eClinical, it's not cut and paste.
Right.
But we're happy to kind of give you kind of a short list, and they can take it and run with it. One of the skills that we've got a large EHR training team, as well as a large analytics team. Atypical, I think for health centers and even provider practices. But in that, we've normalized, let's say, lab ordering. So we have 52 sites. We don't have 52 lab companies, but we have more than one. So we have a generic lab that works for all the lab interfaces, whether it's in-house A1C or referred out. Those are some tips just with labs specifically.
Yeah, that sounds good. I will put my email address in the chat. If that's okay with everybody. That way you can just send me that sample via email. That would be great. Thank you so much.
Sure.
And Yolanda, we will have contact information for all participants, so you will see how to connect directly to Adam.
Oh, you will. Awesome.
Yes.
Great.
I just want, it's 1:02, and I want to be respectful for those who need to get off the call, but I appreciate you all for coming. Again, there's an interactive web map on PCC's website. The link is here. We'll send that out to you folks. That way, if you're trying to figure out, does your state has incentives, just like Adam is mentioning that New York State has, you can find that on the map. Also, if you need help with any of this, PCDC is here to help you. So now you know what we do and how we do it, and how we partner with our organizations, because they were happy enough to join us during this presentation for today. And last but not least, that contact information. So you can make note of all of those who were speaking today. So it sounds like we have Sun River Health on eClinical Works, San Francisco, like Yolanda, is on Epic. So I don't know if Yolanda, if you guys are on Ocean Epic, which has its benefits as a fairly qualified health center specific tool, but certainly you might have some shared experiences, and you might be able to communicate with the folks at San Francisco Community Health. But otherwise, feel free to contact us at PCDC. We're on the top left-hand corner, and we really, really appreciate you guys joining us today. Thank you. We see more questions in the chat. So if you guys want to, okay, let's see. Okay, Dawn, I see your feedback, and we will look to see if there's any opportunities in those other states. And thank you, Amanda. Okay, we got your contact information, Yolanda. Thank you all. Thank you all. Have a wonderful morning and afternoon.
Thank you.